like to welcome everybody here tonight. Dr. Engel, I think, is going to be showing us some really evolutionary things that many of you are directly aware of, and I think tonight one of the focuses is going to be on bringing this and getting this on record so that she can begin to discuss this in a more open environment and a wider environment. But for those of you that don't know, Dr. Engel, this actually is not a function of our hospital, but we're very proud to have Dr. Engel as a member of our medical staff. She's been a member of our medical staff since 2002, and she comes to us from Northwestern University, where she went to medical school and went all the way through her residency in neurosurgery. And we're very, very proud of her. So, and I think most people know her, so we're going to spend a lot of time on an introduction, but I'd just like to introduce Dr. Dominique Engel.
Thank you very much for being here and taking the time of all of your busy schedules, and for supporting me for all those years, like the hospital has, and my patient believing in me and believing in what I think is important to healthcare. I have been waiting a long time for this particular time. It's a change for me. I've been working all those years and learning things, mostly from my patients. Of course, I learned a lot of things from medical school, but the patients put it in a perspective that I didn't have when I left medical school and when I left my residency in neurosurgery. And as you can tell here, there's a book here, and I'm very proud of it, and it's my first, and I believe very strongly not my last. First of all, there are cameramen, and there's a sound and a lot of lights, and this is my first time, but I'm thrilled to be here. The material you're going to hear today is copyrighted, so other than these guys, no recording. I was told to say that. And I would ask you, if you're a physician particularly, to put your phone on vibrate, because we don't want to hear phones taking off. The whole talk is going to last about an hour and a half, and afterwards we will open the floor to patients by giving patients a microphone, but not having them be recorded on the video. And that is to allow this forum to be not just for physician and knowledge and the advancements of medicine, but also for patients' testimony. Because I can stand here and I can write a book and I can tell all kinds of things, but really the proof is there with the patients. And so it's very important that we get some of that feedback and we know that what I am saying is not hot air, so to speak. All right, so there is a book cover here, Chronic Pain, A Cry from the Whole Brain. You see it on the projection as well. And this is going to introduce you to what I truly believe over the years. So let's get started. As Mr. Wentz said, this is not part of the regular hospital knowledge or hospital involvement or any of the physicians at the hospital or any staff of the hospital. This is purely my experience. Thank you. Not just you, but actually the people that I've learned from, which includes people from the 1850s that have written fabulous books with a lot of very valuable information that may not just be quite used as much as it should be. So I'm going to introduce you to some history of neuroscience as well. And I think you're going to enjoy it. Now, don't get thrown off. I am going to speak French. You ready? I just want to read you a quote, and then I will translate it in English, And that quote is from a physician from the 1850s that is called the father of experimental physiology, and his name is Claude Bernard. And what he said is, c'est ce que nous pensons déjà connaître qui nous empêche souvent d'apprendre. I know somebody in the audience who knows exactly what I said. It is what we think we already know that prevents us from learning. And this is very profound, and you will see why, thinking of all the things that I have been against over time, trying to understand some of the difficulties of medicine and the things that we don't know. So I want you to know and look at this slide, and you will notice that it's a bridge in a fog. And every time you see this background of a bridge in a fog, I want you to kind of put yourself in the frame of mind of a physician who is trying to help but really doesn't have all the tools to really do it, or the knowledge or the thinking or whatever else has been found before. And often we are in there. So another quote from Claude Bernard. You're going to hear about Claude Bernard until you hopefully going to go to a library and read about him. Anyway, another quote from him. The origin of an original work is always the pursuit of a fact which does not fit the accepted ideas. Claude Bernard, 1850. What I present to you is not common medical knowledge per se. It's my experiences with a lot of you in a room, and thank you again for my patience to come and support me in this big day for me. This is a no-brainer. This is actually the name I wanted to give to the book until my daughter told me, Mom, this is too 70s and too kitsch. So I gave up and I gave it a different name. But for me, this is exactly what I feel. It's a no-brainer. After I went back to the books and learned and tried to understand why my patients were saying to me the things they were saying, it became obvious. So there's a problem. Belief is not scientific proof. And scientific proof is what we need in order to do things. So looking for a venue, here I am, a book. Okay? Now, thinking again about that, for those of you that are not in a scientific community, you have to understand that there is such a thing as a case report. And a case report is when a physician has an encounter with a patient, does something or gives a medication or has some sort of action on to that patient, and then observes something that doesn't fit. It doesn't fit in what the medical community say it should be. So, can I give you some examples? Yes, I can give you lots of examples of case report. I ran into a case report on the internet or somewhere where basically a doctor was reporting that a patient was complaining of severe pain behind the knee. Okay? Somehow, and I don't remember how, they did look in the cervical spine for whatever reason, and the patient had a herniated disc. And they operated on that disc, and I'm sure they had other reasons to operate. They operated on that disc, and lo and behold, the patient had no more pain behind the knee. That's a case report. That is not something that the scientific community is going to look at like a proof. They're going to look at that as saying, just a case report, one more to stash in the back of the room, so to speak. Okay? And that happens over and over again. And if you look on the internet and you look on previous studies and journals of medicine, there are tons of those case reports, but they are not really scientific, common scientific knowledge from which we draw a lot. And I apologize for the physician in the room that are probably getting bored by now. So there are three main points I want you to take home after this talk. Number one, the whole brain is not the same thing as a brain. And I'm going to clarify that, but the whole brain is a central nervous system. Oh, by the way, that's the reason why when you saw the first slide, there was kind of a funny looking, I don't know, weird brain. Somebody had an idea on what it looks like. A weird brain with a cross across, because that's not just the brain. And I'm going to show that to you. The second thing is, and it's going to floor some physician in the room here, chronic degenerative central nervous system diseases may be treatable or even preventable. The third thing is a sad thing, is we have the power, but we don't do it. That's even more of a shocker, but I don't see any physician falling off their chair. Can we cure diabetes? It's a question to ask, right? Now, I start now with a little history. Here is a slide. Half of what doctors know is wrong. New York Times Magazine, March 16, 2003, Section 6, Exploring Medicine and its Myth. In that particular section of that magazine was one article called The Bittersweet Science. And for those of you interested, it's in the history section of those tables that are back there, so you can look at that article yourself. It is written by somebody called Austin Bunn. And it describes the story of a young woman, a young girl, 12 years old, the daughter of a prominent governor of the state of New York, who was hospitalized in a sort of clinic where she actually was being starved. She had just been diagnosed with type 1 diabetes, and the treatment at that time in 1919 was starvation. Now, how in the whole world did we come to starvation as a treatment for diabetes type 1? Well, in 1871, according to that article, again I'm quoting, a doctor, Apollinaire Bouchardat, in 1871, was treating people in Paris, where, as usual, Paris was attacked by the Germans, and they, sorry, I just have to make a little joke here and there. And people were starving because they were blockaded and there was no food coming into the town. So that doctor had made one observation, which qualifies as a case report, okay? Or a series of case reports. And he had noted that his diabetic patients were actually getting better when everybody was starving to death. So that's how this doctor, in 1919, Dr. Frederick Allen, was starving this young woman, age 12 at the time. By the time she was age 15, she was actually 45 pounds. That's all. But then came along a great scientific discovery, insulin. Now, how did that come along? Well, two doctors, Frederick Banting and Charles Best, in 1922, were taking the pancreas out of dogs and found that the dogs were becoming diabetic. And so they decided to grind up the pancreas and give it back in, and they found that actually the dogs were no longer diabetic. They had discovered insulin. But there's one thing that I want all of you to really listen to and hear. Dr. Claude Bernard, this French doctor that has those great quotes, in 1850 had caused dogs to be diabetic as well. Dogs, rabbits, and cats. That's buried in the books. Actually, it's not. Go on Wikipedia, and you will see it. What's being done about it, I'm not sure. But this is very interesting. Now, the little Elizabeth story, she lived to almost 70. Remember, she was admitted to that hospital in 1919, and it's 1922, okay? And she should have lived no longer than 3 years. That was what diabetes type 1 was at the time, a death sentence. And now with insulin, she lived to age 70. She had 3 children, normal life, and a lot of doses of the insulin. So why do I say that, and why does that apply to neurosurgery? Well, remember I told you with this article, doctors don't know everything. And things change. And in my career in neurosurgery, things have changed drastically already. We've already, in the treatment of trauma patients, have made a complete 180-degree turn as far as using a ventilator to breathe for the patients that I heard. And so Dr. Samuel Shem, who is the author of a book that's also back there called The House of God, was speaking at my graduation in 1989 from medical school and said exactly the same thing. During your practice, you're going to unlearn what you knew from medical school. So let's get straight away to neuroscience. We know that burning pain is nerve pain. We know that the nervous system is a system. We know that the system has electrical properties. And that's where we're going to go now. What about if what we commonly call the brain is not the brain? Here's the beginning of my story with kind of figuring this out. In 1997, I walk in an office, in my exam room in my office, and there sits a little lady, roughly 78 years old, sitting basically on the edge of the seat and rubbing that right thigh. And it's not long into the conversation when she tells me, "Doc, I want my leg cut off. It hurts so bad. It burns." Husband is sitting right there and powerless. And what do the textbook of medicine say? It's the first thing you think about. You're a doctor. You got to figure things out. Complex regional pain syndrome. That's a new name for RSD. For those of you who don't know RSD, that's reflex sympathetic dystrophy. It's a burning pain in one area of the body, and it's a burning that usually thought to be caused by a nerve that has been damaged in a previous traumatic event. This lady had no trauma to this leg or thigh. The second possibility that I'm running through my head as I'm seeing her is neuralgia paresthetica. Misspelled, but generally pretty good. Anyway, the pain is caused by a trapped nerve in the thigh. What is the textbook description of that? Patient is obese, has a big belly, and that is causing pressure on the nerve, the lateral cutaneous nerve of the thigh, and therefore there is pain in that region, and the nerve is not functioning well. She is skinny as skinny, okay? So she doesn't fit. She doesn't fit either of those diagnoses. What to do? There is that bridge in this fog. I could have told her, hey, don't know, live with it. Send her to another doctor, and maybe she get more drugs that help, or maybe she has to live with it. Or search. And I searched. I decided to search. I felt sorry for the little lady, and maybe I could help. What if? Well, I told you in a previous slide that we're talking about a system and an electrical system. So what if something was wrong in a system And then what if that something wrong was remote from the area that the patient had the pain on? I mean, my thinking at that point is, okay, we know it's electricity. There is a light up here. That light is working because current is coming to that light. If the light is out, what could it be? Well, it could be the bulb, it could be the light fixture, et cetera, et cetera. Okay? I don't have to teach you that. You all know that. But somehow we don't think that when we think about pain in an area. Usually we say, well, the nerve is there and that's what the problem is. I don't know why I thought all that, but I did. So where to search? Again, light bulb, you know, compression of the nerve like a carpal tunnel. She didn't fit that, so I had to forget about that. Lumbar spine. I had a lumbar spine MRI that was sent to me by her primary care doctor. So it wasn't there. I saw it. I looked at it. It's not there. Thoracic spine, the trunk, right? You look, I mean, you're going up the system. So it could have been a wire in a wall. That's what I call it now. But if you think about that part, it's like, it's your trunk. There's a rib cage. There is very little movement of the vertebrae at that level. So the statistical possibility that the problem comes from there is low. So I went to the cervical spine and I did an MRI. Why? Because it's a very mobile segment of your spine, and I now call it the subpanel of the electrical system. Now you can see that this slide has the logo of medicine. I found something. Well, if you ventured where you shouldn't and you find something, now you got to make a decision. The patient had cervical spine stenosis. For those of you who are not physician here or health professional, it is where the spinal cord is squeezed by something. A herniated disc, bone spurs. In her case, that's what it was, and it was at C5-6, cervical, between the cervical level 5 and the cervical level 6 at that disc. Now I have a dilemma. No signs on examination that there was anything wrong with the spinal cord. Okay? In medicine, we are looking for signs that were also described in the 1800s. And I will tell you more about those signs later on. So my dilemma is I have no signs. I have nothing to hang my diagnosis on. And, you know, nobody knows that the neck has anything to do with the leg. That's to be revisited, actually. And worst of all, she had no neck pain. So you can imagine what goes through my head. Okay? I feel sorry for the little lady. I had her already come back 2-3 times. I have tried to figure out a problem. What do I do? I still have the option to let her go. Okay? It's too dangerous, too unknown. I maybe shouldn't cross that bridge. I could have sent her to another doctor. And that's an important point, because those quote-unquote myelopathic signs, those signs that tell you that the spinal cord is hurt, those signs are not there one day and stay there forever. They come and go, depending on how tired the patient is, how stressed, how the condition at that time is. If anybody else had found those signs, any other surgeon would have found those signs, they would have been able to operate, because they would have been within the standard of care, the current standard of care. And we're going to revisit that at the end. And I may make some enemies, but I'm going to say it. Free speech. What to do? Offer an operation after considering all risks and benefits and adding a warning. Spinal cord compression is bad for you, but it doesn't cause burning pain in a leg, or at least I don't know. Options. She can have a leg cut off. I don't think any physician in their right mind would have done something like that because phantom pain. Just talked to somebody in the crowd about that a minute ago. Live with it. Not a great option. Drug after drug, pain after pain, no fun. Not a good way to live. Operate. No. Warning for the lawyers in the room. She's taking a risk. After all, she's 80 years old. I warn her, but you never warn patients enough. She's 80 years old. She can have a blood clot in her leg. She can have a heart attack. She can have who knows what, a stroke. She can die. I am taking a risk. It would be a lot easier to say, hey, go live with it. It's not my problem. And if she has an unforeseen event, how do I hold my position in court when the patient had no neck pain and no signs? I'm done. I might as well pack up and find another career, right? I was extremely lucky. I don't know, maybe I was foolish. But in 3 weeks, the pain diminished. In 6 months, by the way, this lady was taking 2 Vicodins every 4 to 6 hours around the clock. I operated on her cervical disc. I did a fusion, like what is basically standard of care. Cleaned up that disc, made room for her spinal cord. Within 6 months, she was no longer taking any medication. She at age 80 or so, healed that fusion beautifully. They thanked me. Everybody went home. We didn't go to court. But I was stuck with a conundrum. Now I don't know what to do because this is now stuck in my memory. And I'm not going to stop thinking about it every time a patient comes around. So I started to examine the people, especially when they said they had burning pain, and I would do pinprick exam and light touch exam, and then for some reason, which is understandable at the time, retrospectively, I was stuck on the thigh, because the thigh is where I'd found something abnormal. I know I mentioned to you the only abnormality she had, abnormality she had on exam was the fact that you could touch with light touch or you could poke with a pin, and even though this was the area of burning pain, she didn't feel anything. So then I come to call it the silent maimer, right? I mean, it didn't kill her, so it maimed her. It made her life miserable. She had no neck pain. I had no sign. It was silent. But I started thinking, how come it is silent? Well, if you think about it, and I bet you a bunch of you and the doctors in the room know, you can go on Discovery Health and you can watch a show where you will see a patient get numbed, the scalp, the skull cut out, patient is awake. A needle, blunt needle, so no bleeding, but a needle nevertheless is introduced in an area of the brain that is to be tested by the doctor. And the patient is awake, and the patient tells you, you're touching my hand, you're touching my foot, you're doing whatever, depending after you put electrical stimulus to that area. So not only you put a needle, but on top of that, you're putting electricity through the needle. You're zapping that person. And never, ever, I challenge you, because that I'm sure of, never anybody's going to tell you, take the needle out of my brain, because they don't feel it. Because the brain doesn't feel anything. So the spinal cord doesn't feel anything either. So there it is. whatever that disc was doing, it was hurting the spinal cord, but it was definitely not triggering a painful stimulus to the muscles, the joints, the tendons. It wasn't causing anything else, and that's the reason why it was silent to her. To me, the myelopathic signs, I told you already, come and go. So these are also can be silent intermittently. So I listened and I observed, and I listened and listened and listened and listened to patients. And I just took long histories, and I did a lot of examination, and I started asking about this, that, the other. Over the years, I got worse and worse. I want to know everything. You coming to me with low back pain, and I'm going to know everything about your bladder function, and I'm going to know everything about your gastrointestinal function. Can you digest food? Are you on and on and on? Why? And that's because I'm thinking the whole brain. I'm afraid a lot of it, we have forgotten the forest for the trees and the container. That brain is also sitting in a container. So now let's go and talk history. This is a fabulous book, and I have to give credit to this book. This is called Origins of Neuroscience. It's a history of the exploration into brain function. And it's basically telling you how all the discoveries were made along the way, what area of the brain does what. And we're going to get into that. So before we get into that, I want to put some definitions up front for you to think about. First of all, what is a paradigm? Second of all, localization of function, which is a sort of a paradigm, or falls into the spectrum of a paradigm. And then holism or gestalt, okay? What? A paradigm, first of all. A paradigm is a framework. It is like if you build the rough frame of a house, whatever happens to that house, everything has to go within that frame. Just think simply that people that don't go into that paradigm are thinking outside the box. That's pretty much what I was doing. I don't think that should come to a surprise to anybody. But that's a paradigm. And now you see the medical logo, and you see the definition again, and now we're talking of localization of function. Localization of function is a paradigm. Therefore, it's a framework. Therefore, we have a tendency to think localization of function. So if you think about localization function, what does the spinal cord do? Well, the spinal cord controls your arms and your legs, right? It's pretty obvious, right? Speech areas, motor areas, sensory areas, all those things, Broca's areas, all those things are in your head, not in your spine, not in your spinal cord. Makes sense? How did that get started? Phrenology. I'm sure I kind of threw that in, but I'm sure you all heard about those doctors that were looking at the bumps on the head and wondering if we could figure out what people were like or what their brain was like by looking at the bumps on the head. Well, those people actually, you think about hydrocephalus, it's not all that stupid, because if you have water on the brain and it's at a young enough age, you can have a big head. But those people started a trend, and everybody jumped on that and started looking at the brain itself, and then there was electrical stimulation of different areas of the brain, and then we discovered the speech areas, etc. And then there was a Dr. Golgi in 1926 who described the nerve cell, because he found a stain that you could apply to the nervous tissue, and you could see the individual cell. And nowadays, we are going even further. We're looking at the synapse, and now we're starting to look at the genome and the genes to try to figure out, do you have the gene for Alzheimer's? Maybe I'm swimming upstream. Those of you that know me, I can do that very well.